So I'm very happy to introduce Dr. Black, who has been at Regents as an assistant professor for the past 5 years, and has been very active in teaching our medical students. And so I have the pleasure of meeting him instead of sending emails, anyway, as clerkship director. So Dr. Black obtained his MD and PhD from the University of Illinois, Champaign-Urbana, with a PhD being in neuroscience, and has had a very long track record of very diverse kind of education and research at all levels of teaching. Was at the University of Utah, finished general psychiatry residency there. Has a very long history of R1s, being investigator, being co-investigator, and author of I think I counted about 150 publications. So I'm very happy to welcome him on part of our department, and turning over to him on a very interesting topic of moral injury and psychiatric aspects of guilt and justice. And I know PTSD will be kind of included in there, and I'm very happy that he's also one of our substance use experts in the Twin Cities. Thank you, Dr. Black.
So thank you for inviting me and rescheduling. That was very much appreciated. This is a new topic for me. My background is in neuroscience, and new for our research group. It's a pleasure for me to talk about this topic of moral injury. And this is unusual for, I think, grand rounds and topics in psychiatry, in that we'll be focusing on kind of a larger perspective of guilt and injustice. Old-fashioned psychiatry. I'll talk about how this is a new topic in our group. We're learning so much so fast. We try to answer a question and we get 10 more questions out of it. I'll try and convey how fast this is moving right now. So some business. There are no disclosures, no conflicts of interest, and I do talk about some individual patients I've worked with. I disguise their identities in here. So grand rounds used to involve cases, used to involve presentation of a difficult case. I'm going to start with a case from the DSM-3 casebook, so it's quite old now. I've been using this in teaching for about 20 years. So I'll just summarize the case for you. A 32-year-old veteran admitted after an overdose to a VA hospital. He's been depressed since coming from Vietnam in 1972, so the case is set basically in the 1980s. He hated the war. He especially hated it because he once went berserk. He killed a civilian for the fun of it. Now, berserk is an interesting word here. It's an old Norse, it's from the Norse legends. The warriors would lose control. They would become like animals, savages. They would bite at their shields and strip naked and fight. Just terrifying, non-human warriors. So this term used here conveys how much he lost it. This is something that when you talk to the veterans, when you talk to active duty soldiers, they're very reluctant to talk about, but it's very real. The heat of battle, there's different terms for it. So to summarize, before Vietnam, he was had a regular job as an electrician. He was respectful, polite, had a good life. When he came back, though, he was broken. He was a loner. He had sexual relations, but no romantic relations, no family, no friendships. He was a heavy drinker. A punishing drinker would be a good way to describe it. He was always angry, always bitter, chronically unemployed. I think in the case, he only held a job for a couple of weeks when he was employed by his uncle. And eventually he becomes disabled. That's where the case starts in the DSM-3, that he develops alcoholic dementia. So he is broken. He has ruined his life for a decade or more, and now he is disabled, demented. What went wrong with him? So this is one of my favorite pictures from the Vietnam War. This is like a Renaissance painting. Look at this and think about what it's like to be in the heat of battle. Think about what it's like to be trying to fight for your life, fight for your buddies' lives. killing is not a natural human activity. Military training makes people good at this, but it's never easy. This is among the most terrifying and unnatural places for humans to be. It's unfortunately pretty common. So what happened to this man? Imagine our veteran here, and then he comes back. What happened to him to make him broken? So this is actually part of where our research started, was asking questions like this. What happened to him? When I teach this case, almost always the response I get back is that, oh, it's PTSD. He's a Vietnam vet. He was in the war. He came back. He's not doing well. He's depressed. He's drinking too much. It must be PTSD. I don't agree with that. I don't think that's the right diagnosis. I've had a clumsy phrase for this. I think that he's troubled by guilt. So I used to call this post-guilt disorder. I was trying to figure out a name for it, but guilt is he's troubled by what he did, by the killing. So it turns out that other people have been working in this area, particularly from out of the VA. Jonathan Shea, the first name down at the bottom, is, I think, the original worker in this. He's a psychiatrist out of the VA in Virginia, I think. And he was troubled by all of these Vietnam vets that he worked with, where it was more than just PTSD. It was more than trauma. They were deeply troubled. They were troubled in their soul. It's kind of, he calls it a soul injury at times. They have witnessed things being done. Shea initially focused on things done by someone in authority, a commander, a leader who betrays you, ends up getting people killed for no good reason. You can imagine the four-letter words, the emotions that go with this. So the betrayal by someone in authority. But Shea and some of the others have also started to include, what happens if I'm the one who goes berserk? What happens if I'm the one that makes a mistake that gets people killed? What if I'm the one who broke the laws, who had a moral transgression? And then more recently, they've brought it out to ask, what happens to people who are just witnesses, bystanders to bad things, evil things happening? What if you're not the perpetrator? What if you're not the victim, but you spend days or months in a combat tour witnessing terrible things? Does that have an effect on you? So the term that they've developed is moral injury. I like this term. It's much better than mine. The moral part, I'll emphasize that this is not trauma. It's not stress. It is something to do with our cognitive system, considering moral rules, laws, our integrity, our definition of self, who we are. So this is an interesting concept. The other part here that Shea put a lot of emphasis on is that this is a combat injury, the original concept. These people are wounded, they're hurt, they're broken sometimes by this. This is a potentially life-threatening injury. He ranks it up there with losing a leg, with the other Purple Heart kind of injuries you can have. This is something that damages people, the soldiers, for long term. These different references I have down at the bottom, there's a lot of emphasis on this being a high-stakes situation. So think of combat, obviously. This is not the standard wear and tear of the workplace or your neighborhood. This is life and death, high stakes. People may die because of what happens in this. The transgression deeply wounds the person. Like I was saying, this is not something you can shake off. This is not something you can do, go to church and say some prayers and it's all taken care of. These are things that stick with people. So again, think of the veteran that I talked about, that for over a decade, as he lived with this injury and he coped with it. Another thing about this veteran that I'll come back to is that I suspect, it's not in the case, but it's an interpretation, I suspect that the veteran was punishing himself, that he couldn't have a romantic relationship. He didn't deserve to have friends. He didn't deserve to have a job. He was a bad person because he committed murder, and he needed to be punished, hence the drinking, the debasement, proving that he really is a broken person. Right, so we became interested in this concept of moral injury, and there wasn't a whole lot out there. Some of you are familiar with this because you saw it in some of the magazines and news broadcasts. It was broadcast, some of this was broadcast on NPR, the Atlantic magazine, Huffington Post. There's a whole bunch of popular press Not widely known, but I've met people who've encountered those articles. We started looking at the literature. There is nothing there that would justify a meta-analysis or a systematic review. There's actually very little research. So we used an approach called a scoping study, which is kind of the qualitative version. It's a cousin of a systematic review, but of looking broadly at all of the literature on this topic of moral injury. Very inclusive, very far-ranging, like it sounds, a scoping study, searching things out. It turns out that this is a very new concept. About 90% of the published literature is less than 5 years old. Now think about other things that you are learning about or studying or doing research in. This is a new topic. Also, 90% of it is related to the military. There are very few people like our group that are branching out past veterans. This is a very new, a very narrow research area with very little published, very little systematic research studies. Now, because we were doing a scoping study and a very broad look, is we started discovering some interesting things. It turns out this is not a new concept. It's actually quite old. So I made a reference to old-fashioned psychiatry. We'll talk more about this, but there's some related terms. Those of you in nursing may recognize the term moral distress. So moral distress is now taught at most nursing programs. It's routine. It's related to nurse burnout. It's a kind of chronic ethical wear and tear. Betrayal trauma, those of you interested in psychotherapy may recognize that term, related to childhood sexual abuse, children betrayed by their caregivers. The second victim is a term that was new to me, but you recognize the general concept. That's physician errors. It started with physicians and surgeons making errors and what happens to them. So not only does the patient get hurt, there's a second victim, and that's the surgeon. The surgeon made an error. Somebody got hurt. That's a violation of our core sense of self, our core values, that I shouldn't have done that. All that self-talk that goes with it, and a fairly high risk of addiction, depression, even suicide. So it sounds a little strange, but think of the surgeons who make a mistake. Think of nurses who make a mistake. And it's not in the literature, but think of police officers who make a mistake or lawyers who make a mistake. When you have a professional...
What about psychiatrists?
What about psychiatrists? Yes. So when a professional has a code of behavior and you make a mistake, it's a moral injury. Not called that in the literature. They're calling it second victim. And then this other one that I was not familiar with until recently, enduring personality change after catastrophic experience. And we can talk more about that, but that's actually an official, it's not our diagnosis, but it's an official international one, ICD-10. Think of how people are affected by catastrophic experiences, disasters, war, but also think about what happens to people. You know some of these people who've had something terrible happen to them, a spinal cord injury, cancer, a bad car accident, a bad divorce. You know some of these people who are deeply affected by this. They carry that resentment, that bitterness with them for years. Okay, so remember I started with a PTSD case, or what looked like a PTSD case. Just a slide to kind of emphasize that I'm talking about two different things. So this is the most common confusion, and when we were doing our literature reviews, we found over and over again the dissertations, the publications would kind of blend these two together because they're working with veterans and they're quite often comorbid. So just a thought experiment, PTSD can often occur without any moral transgression. So let's keep it simple. Think of a tsunami, a tornado hitting Kansas. That it's nobody's fault, nobody did anything wrong. It was just a big disaster. You can have fully fledged PTSD, all the physiologic symptoms, all the intrusive memories, everything about PTSD, but no moral guilt, no moral issues. And you can flip that around. You can have moral transgression, moral injuries, moral crimes, whatever you want to call it, that can occur without any trauma. Now here, you might have to think a little bit, but think about the person who embezzles money. They get into a desperate place, and they start stealing from the till, or they steal from their company, or they lie on their taxes. So a lot of times you say, well, that's small potatoes, but sometimes it's a big deal in terms of the code that they're violating. Sacrilege for people who are devout, very deeply religious, that when they commit a sin, that there's not so much the trauma, but the sin of like you broke your code, you broke the rules. Having an affair, a extramarital affair, is another example where there's no trauma involved, but it can be deeply disturbing. And I'll give you an example from one of my residents in a minute. So, backing up again, PTSD is an anxiety disorder. Moral injury is something different. It involves meaning. It involves moral values. Where in the brain are those? Defining oneself. Like, this is who I am. That isn't what I should be doing. And social context. These are the social values. So, some more information about meaning here. So, moral injury, there is intricately connected to meaning. Again, different from a lot of what we talk about in modern psychiatry. So think about, again, a thought experiment. Think about the terrible things that can be tolerated if you are true to yourself. True to yourself, you keep your word, you're virtuous. If you are treated fairly by others, if you're given the respect, think of the heroes that you learned about in childhood, you read about in the news, the 9/11 firefighters, police officers, the surgeons who heroically saved lives, the soldiers. So these are brave people who can do amazing things under terrible circumstances, and we respect them. And in spite of all the stress and distress that they had, is they come out of it feeling virtuous, feeling okay, in spite of all that. Those same events can destroy a person if you're breaking your rules. If you're a POW and you cave in and you switch sides. If you are a coward as a soldier. So if you break the rules, if you break the rules about defining yourself, the moral code that you live by, you tend to have very bad outcomes. And this is where I was talking about people becoming depressed, suicidal, or more importantly, is people who are self-defeating. There's something about this moral injury where people decide that if I'm not a good person, unconsciously, they prove it. They go out of their way to prove it by sabotaging things. Now, as I said before, these are old ideas. Think about sacred texts that you're familiar with. Think about Shakespeare. Think about the great books you read in high school and college. This is quite often a theme of justice, of virtue, of interesting stuff. Now, I remember reading some of these authors when I was a med student and the resident. Robert J. Lifton, the older folks probably recognize the name. Arthur Kleinman, that all of you should know, I think. The Illness Narratives, an excellent psychiatrist, anthropologist. Viktor Frankl, another name that all of you probably know. So, new concept, new area of science, old ideas. But again, some more stuff about PTSD and moral injury, just kind of contrasting and showing similarities. So both of them have an adverse event. Something bad happens. In PTSD, it's a threat of harm. In moral injury, it's a moral code violation, a moral transgression. The emotions for PTSD are mostly anger, and you guys know that often you get, it's mostly anxiety, but quite often you get anger with that. Moral injury is still new, but we're thinking that the emotions are not the same. We're seeing a lot of guilt, shame, no surprise there, but also alienation, kind of that old concept of enemy, and a lot of anger. The valence, PTSD is about something out there that happened. The moral injury is about something in here, internal, that's broken. The physical is interesting, sympathetic arousal in PTSD, but we're thinking from talking to people that disgust, an old infantile emotion, that may be kind of central to this. Disgust, nausea, heartbroken. We hear a lot of words like that. Most of our subjects can't describe it very well. This is not in the easy vocabulary, accessible vocabulary. Intrusive memories for both, rumination for both, disturbed sleep for both, numbing for both. The neuroanatomy, we could go into a digression there, but it's interesting, very well understood for PTSD, not so well understood, but there is a research on morals and functional MRI. It's actually a an emerging area that's interesting. Orbital frontal cortex, insula, but more executive function, prefrontal cortex. And the complexity, PTSD is old brain. That's your lizard brain at work. Moral injury is more cultural, social, moral values. It's very hard for to do measures of this, but it's getting very interesting for us. This is very different from PTSD. So, classic painting. This is Macbeth instructing the assassins. I'm changing gears here, and we're talking about mental health, mental illness. So remember Macbeth and Lady Macbeth conspiring, plotting, murdering, getting covered in blood, and eventually going quite insane. So, mental illness. So I'll give you some case examples. I'm going to give you a lot of cases in the next set of slides. So the first one is the one I got from my resident. After confessing a long affair, years-long affair to his wife, this 45-year-old man was depressed for years, so he's followed in therapy for years after that. He's been working long hours. He's working 2 jobs. He is trying very hard to avoid his family. He goes to the kids' ball games and the plays. He does all the right things as a father, but he's not in the family. He doesn't sleep in the same bed with his wife or in the same room. He sleeps in the basement. This is like literally being in the doghouse. Doghouse as in with the fleas out in the cold. You don't belong in the house. You belong there. So he's sleeping in the basement. This doesn't come to a good end, although he's still in therapy, but he starts smoking meth. Now again, I'm interpreting, because I'm not the treater in this case, but I'm interpreting this as he has decided that he's plagued by guilt. He's broken by the guilt. He can't see any way of being part of this family because he's not a good man anymore. He's a bad person. And ultimately, he's proving it, self-sabotaging by getting into smoking meth. Speculation, but it's interesting in terms of the moral injury here is the original affair, and he's compounding it by going deeper and deeper into his problems. The next one is someone I treated, a 60-year-old grandmother who was hospitalized for depression. After working with her, she discloses great shame and anger that she did not pursue charges against the man that molested her daughters years and years ago. So we're talking like 20 or 30 years. 20 or 30 years of carrying this around, knowing she could have done something. Actually, she's taking too much responsibility. She thought the statute of limitations had expired. But looking back, she says, I could have done something. And now in the hospital, she's telling me, and this is a smart woman, she's telling the psychiatrist, I wish I had killed him. She's that mad. So she's troubled by that too, because now she's talking about being a murderer, but she is deeply troubled by betraying her daughters and by having these homicidal thoughts about the perpetrator. The next one is a 55-year-old engineer that I treated. He had withdrawn from his family and his work. He'd withdrawn from all his social activities. He stayed at home and watched TV. He lost 60 pounds in 3 months, which is a lot of weight loss. He had been kind of an athletic guy, and he just wasted down. He confesses that when he's locked up with us, he confesses that he committed a terrible crime, one that deserves the death penalty. But he won't tell me what it is. Now, we got releases of information, we asked around, we could not find any crime in the papers, among his relatives. Quite plausibly, this is delusional, psychotic depression. But I think it's a mistake to describe him with your DSM code, psychotic depression. I think that reduces his story down to the point where it becomes almost meaningless. I think he's troubled by this crime. Even if it's delusional, it's what's important to him. He's punishing himself. He's starving himself to death because he doesn't deserve to live. So I think the meaning of this is important. Right buttons. So one more mental illness one. This is in the Toronto Star. So if you Google the patient's name and Toronto Stars, you can read a long form article, which I'd recommend to you to kind of get into what this is like for someone when they make a mistake like this or commit a crime like this. So in 2002, Michael Stewart killed his mother while psychotic. He was responding to command hallucinations. Michael is now out. This is years later when the article's written, the newspaper article's written. He's now out. He's stable. This is one of the best schizophrenia patients with schizophrenia that you can imagine. He's very compliant. He's got excellent services. He's doing well in the community. But that's not the point. If you describe him as someone with schizophrenia, you're missing the point of what's happened to this man. When he got better, is he has to struggle with the knowledge, full knowledge, because he went to trial and everything, full knowledge that he killed his mother. And his family knows that. So his family visits with him, but he knows what he did. So the quote from the newspaper article, when his thoughts wander into uncomfortable territory, he stares out the window, counting birds on a telephone wire, and forces his mind to go blank. Not negative symptoms, not psychosis. This is moral injury. The psychiatrist, the forensic psychiatrist who treats him is well known in Canada, talking about patients like this that he's treated. When they recover, the enormity, the impact of what they've done hits them and they can't forgive themselves. You've got to get them to redo their thinking. That person wasn't me. Okay, so I'm working with people in social work. I'll list their names at the end. So an interest in child welfare. We've started one of several studies. This is the one that's furthest along right now. A mixed method study interviewing CPS Child Protection Service involved mothers and CPS professionals. So the caseworkers, the administrative staff. We're looking at the involvement of the mothers. We're using a moral injury inventory that was adapted from the VA studies. So this is one where we have to adapt it a little bit, but this is a well-documented, well-studied tool or measure. We're doing semi-structured interviews and we're gathering this information. Now think about the parents who are involved with CPS. They're involved with CPS because something went wrong. There had to be something terrible that happened that CPS got involved. So they already have a lot of guilt and shame, whether it was an accident or not, whether it's a misunderstanding. Having CPS involved with your case is embarrassing, shaming. It causes a lot of guilt, in addition to the guilt you may already have because something happened to your child. Now, in addition to the parts of being a parent with a child who's had something happen, there also is the harassment, the bureaucratic aspect of child protection services. It is a bureaucracy and things don't always go smoothly. So quite often these parents, when we talk to them, have lots of complaints. They have often complaints about injustice. So you could say, well, sometimes they're in denial of what they did. That's common. But they're really angry at unfair treatment by CPS. They're making me do this and that, and it's not fair. In addition, sometimes CPS is not doing fair things. We're also looking at the CPS workers, and our concern here is from past research. We've worked with child welfare case managers. It's a high turnover, high burnout, very emotionally difficult job. We're interested in whether, instead of what I used to describe that as PTSD, you hear all these terrible things, you take it home with you. Like you were saying, this happens in psychiatry all the time. We hear all these terrible things. But I'm starting to think this isn't PTSD. I'm starting to think maybe this is moral injury, that you hear about moral transgressions, bad things happening, and just witnessing that, just being part of that, has a wear and tear on people. So we're looking into this, and it would apply obviously to other people in mental health. A couple of cases. A mother left her 4-year-old child sleeping while she went to the liquor store. A neighbor called police when the child woke up screaming. So she went off just for a quick little break, and while she was gone, the child woke up and missed mommy, and the police were involved, and she got involved with CPS. When we saw her, she was well into recovery and deeply troubled by what she did. So this is like people in recovery from substance abuse, that they look back and they, how could I have done that? That isn't me. For moms, this is a break, a transgression of a deeply held code. You don't abandon your child, you don't neglect or abuse your child. So she feels deeply ashamed. That turns out to be a therapeutic issue, the shame part of it. The next one is an acquaintance. An infant falls from the changing table and dies. Obviously very sad, devastating. The parents are understandably distraught. They're grieving. Part of the hassle here, part of the moral injury, in addition to blaming themselves for what happened to their baby, all the terrible feelings that go with that, is they're kind of ticked off at child protection, because child protection comes in and says, you know, you don't know what you're doing. You don't know how to change a baby on the table. You must have turned your back. You must have been using drugs. So all of this finger pointing and nagging, and that doesn't help. Now, that's just one example, but sometimes CPS is not being helpful. I think sometimes other professionals also get into this blame game. In this next case, this is one of my patients, a psychotic mother. She's been out smoking meth. This is a chronic problem for her. She is psychotic and has the formication, the feeling of bugs all over her. She pulls the toddler out of the car seat, throws him out the window, and proceeds to pound on him to get the bugs off him. I know, it sounds terrible. The baby was taken to the hospital, placed in foster care. The baby's okay. In this case, I was working with this mother earlier in treatment, earlier in her recovery from the addiction, and she was not in a place where she had any remorse. She was very angry at CPS, very angry at the doctors, angry at everyone except herself. She took no responsibility. So in a twist here, as I would argue, she has addiction, she has all kinds of problems, but she doesn't have a moral injury. She has no regrets. She doesn't see a moral transgression. She doesn't see that she caused a problem. Everyone else caused the problem. So what we might see as a moral injury or moral transgression, not everyone else does. Substance use disorders. In this case, a 35-year-old successful executive blacks out drunk, crashes his car, and kills his fiance. So this is terrible. It's in the newspaper. He's facing a lengthy time in prison. He entered rehab where I met him. I'm having some substantial countertransference here because he's not interested in getting sober. He doesn't feel remorse. He wants to get a more lenient sentence. So I have my issues. I think that he did not suffer a moral injury because he doesn't have any feeling that he had a moral transgression. He doesn't accept that he did anything wrong. We could argue back and forth, like maybe it's just denial. Maybe deep down inside he knows that he did something wrong. He committed murder. But when I was talking to him, it wasn't there. The next one is a 42-year-old man that I treated for ECT, for bipolar depression. In the midst of all this treatment and discussion of meds and ECT, it turns out that he had an issue of shame or guilt that when his mother was dying of cancer, as he stole her OxyContin. So we hear that story a lot these days. The thing is, you might say, with everything else going on, with his bipolar, his depression, the ECT, all that, why is this a significant issue? Because he said so. Okay, he made it a big issue when working with me. This tormented him because it was a bad thing to do to your mother when she's in pain and suffering. So he recognized this. So I would say this is a moral injury. In the scope of things, it may be a small part of his life, a small, short period, but it bothers him. It would be something to work on in therapy. The next one is an acquaintance of mine, not a patient, 24-year-old woman that I met years ago, whose fiance killed 3 kids when he was a teenager himself. So it's a drunk driving accident. As far as I know, I never met the fiance, but as far as I know, he went on to have a good life and a good marriage. And this woman loved him. He's the fiance. But how does one live with that? How does this fiance who killed 3 people when he was a teenager, how do you move past that? You could say, I was just a kid. You know, I was incapacitated. There's lots of things that go with that. But how do you work on that? How do you deal with something that you can't forgive, you can't forget, you can't ignore it? You don't have to share it with everyone. But this is a big burden. Okay, community level. So I'm switching gears here to looking at a higher level, community level kind of moral injury. So think about refugees. I was influenced by Cheryl Robertson, who's in the School of Nursing. Refugees, internally displaced people, so think of wartime, think of disasters. Communities facing prolonged conflict. So in this case, you could think of Flint, Michigan. You could think of Hurricane Katrina in New Orleans, the Ninth Ward. So think of communities where terrible things have happened and the injury is going to last. So I contrasted that with the tornado in Kansas, where I used to work. The tornado in Kansas comes and goes. The community can often be resilient and generous and people come together. That's not always true. In places where there is chronic, ongoing conflict, it can be much worse. So this is my term, and it's open to debate here, but I'm arguing that there's a kind of complex moral injury. So I've talked about kind of simple moral injury so far. In a complex moral injury is you have multiple overlapping problems. So quite often, again, from Cheryl Robertson, but quite often when I work with this group of patients, is I find out that not only were they victims of torture or victims of war, but also they were perpetrators. So quite often to survive, you have to do things that go against your moral code. Being a sex worker, stealing, even murder, and with all the stress that's going on, quite often child abuse. So it's not like you, it's not in your values, but with all the stress that's going on is you might hurt your kid. Okay? You might have domestic violence. It's not like you, it's not your values, but it goes against that. So being the perpetrator, being the victim, and also being the bystander. Remember, these are communities where your neighbors are being hurt. Your neighbors are refugees as well. So being a witness, perpetrator, and a victim all rolled into one. And these patients, when I've been paying attention to this recently, is they're enormously complicated. There's also in these communities a breakdown over time in the family organization, the community organization, and even the culture over time. It's devastating, and it's like a flood that just goes out, affecting everyone. There are additional stresses, not to be minimized, of medical illnesses, PTSD, poverty, and broken infrastructure. So at a time when you need support, when you need services, it's not there. Your extended family is not there, maybe even your own core family. Okay, so a quick example, just one example. This is from a child soldier. It's from a paper, Child Soldier Narratives, and this is an emerging area of research. Child soldiers often have especially complicated psychological responses. It's not just, in the literature it says PTSD, but I think, again, this is looking like it's more like moral injury. So this is from Baines. It's describing a woman named Sarah in Uganda who was tormented as a child. So lots of child abuse, lots of terrible stories from growing up. But then she was kidnapped by the Lord's Resistance Army, was made a child soldier as well as a concubine, and multiple pregnancies while out in the bush fighting with this army. She ultimately was freed. She ultimately was able to return to her tribe, her community, but they're afraid of her. They're afraid of her because she's a child soldier, and those people are very dangerous. So she's stigmatized. So this is like betrayal trauma. The people you should be able to count on don't want you anymore. So this long quote, "It is true," from Sarah, "it is true that I was in the bush and I can accept that I killed soldiers at the battlefield, but outside that I haven't killed anyone. In fact, I was the one whom they committed violence on. I did not kill anybody, but if you've now started seeing me as your enemy, then let me leave. It is better than having to live with you and feel hurt." So this is a moral injury, I'd argue a complicated one, but she is deeply injured and wounded and broken by all of this. Related concepts, I hinted at this earlier. Moral distress from the nursing literature. When we were doing our scoping studies and kind of counting how many publications, hundreds if not thousands of publications on moral distress, a very well-developed area of research. We're still looking at it because nobody in the moral distress literature cites moral injury or vice versa. So this is an interesting question in its own right. What's the connection? What's the overlap potentially? The second victim one that I mentioned, with initially focusing on surgeons, physicians making errors, but more recently it's extending to nurses and other professionals who make mistakes. I would argue that's like one of the closest parallels to moral injury, because it breaks a part of you, a value that you hold dear as part of your self-definition. Physicians in particular are very sensitive to like losing licenses or having errors like this, and this is, I think, one of the closest analogies to moral injury. Again, no overlap in the literature. We're talking about two different things. Post-traumatic embitterment disorder, I didn't mention this one before, but this is Lyndon in Berlin, who's been studying this for a while. He's looking at that group of people where something bad happens and they can't let go of it. Again, all of you know this from working with patients. You probably know people, maybe in your family or other acquaintances, people who were hurt badly by a divorce, a medical illness, something bad happened and they can't let go of it. They hold on to it with this chronic bitterness that affects their personality. There are cases I could share with you, but all of you probably know people like this. Psychiatry is a culture-bound syndrome that we came across. Again, no overlap. This is a group of people studying refugees' mental health. It looks like it has flared up with the wartime, the guerrilla conflict in West Papua. This is an old culture-bound. It used to be something you'd see in families with domestic violence. Something bad would happen. People would hold on to this injustice and they would lash out. So it's a cousin of running amok. Remember from DSM? So it's a cousin of that. But in the conflict, the war conflict in West Papua, it looks like this is becoming endemic, very common. And it's a wartime kind of, it's a response to wartime conflict. It looks like chronic resentment. This isn't fair, this isn't just, and it boils over with violence. So in one case, violence, I was talking about doctors with the second victim, often substance abuse or suicide. There's different forms of response, different ways people respond to moral injury, but I think there are connections here. The last one is the one I mentioned, enduring personality change after catastrophic experience. The nice thing about that one is that's an official diagnosis. It's easy to track down the literature. It's not a big literature, but it's an official diagnosis. Okay, another classic painting. This is from the late 19th century, before the Soviet Union. Ivan the Terrible, so the Tsar with all of his crimes against his own people and others. So a terrible man. Okay? At the end of his life, he felt bad. He repented. He actually tried to join a monastery to become a monk. So all of his wealth he gave away, all of his power he gave away, and he became a monk. So this painting is of him begging for forgiveness for all the bad things that he did. So the reason for this painting is I'm going to talk about recovery or treatment for moral injury at this point. Okay, here there's not a whole lot of work. The VA has been doing a couple of approaches that I'll highlight, but there's not much work on treatment for moral injury. In our scoping studies, we came across a lot of sermons, Sunday sermons, from ministers all over who are picking up on this idea of moral injury and using it in their work in the ministry. So we started thinking about this, and it's clear. It's like I said, it's a new concept but an old idea. The church, different versions of the church, have been doing this for thousands of years. They've been helping people deal with guilt, with forgiveness, and so forth. So there are institutionalized ways. Whatever you think of particular churches, is that this is institutionalized. It's a way that is accepted of working your way through a moral injury and recovering from it, or helping other people recover from it. People ask me periodically, like, how would I treat someone like the CEO who's facing prison time, or the fiance who killed people when he was a teen? I don't know. I'm still learning this. But here, the church has thousands of years' experience. Common phrases when we're doing our study of the people, the subjects, is we hear kind of common words. And some of these are from people, we hear most often from people who are not troubled by their moral injury. They're not depressed. They're not disturbed. One of these is an administrator in a law clinic that works with child protection, and she's a person of faith, and she just rolls with it. She's not disturbed by the things that she has to deal with. And she and the others use words like faith, reconciliation, serenity, making amends, good works, repentance, atonement. So the spiritual side of things. We don't know much about this, but it's very interesting. We're in the process of starting a study related to child welfare. These are a group of nuns who work with widows in Ghana. So they're dealing with moral injury with the people that they're helping. But they also deal with it on a daily basis. So we're going to be talking to them to see how they use their faith to deal with kind of the wear and tear of working with widows and orphans every day in their work. Something that should jump to mind when I'm talking about recovery is 12-step programs. So again, not centuries, but a well-established, well-known approach to dealing with forgiveness. So think of all the alcoholic addicts that you've worked with over the years, that they're deeply troubled when they get to that point, when they get far enough along in their step work, they're not in denial, is they're faced with terrible memories. By definition, it's not a problem unless it's causing problems. So they've got stuff to deal with. And quite often, that's one of the hardest things for people in recovery to deal with, is looking at the past, looking at what they did. So 12-step programs are designed to help people forget the past, to forgive it, to make amends, to move past it, and to do good deeds to help other people in recovery to get past that pain. An official kind of therapy that I was interested in used in the VA, narrative exposure therapy. So exposure therapy is your classic PTSD therapy, but in this case they're kind of doing a hybrid of narrative therapy and exposure therapy. But the veterans, when I work with them, they're often deeply disturbed. It's very hard to go through this, but instead of just focusing on the visual, the smell, the triggers for the PTSD anxiety symptoms, in this case you work on the narratives, the meaning, the moral codes, what happened. You work on it that way. Now, interestingly, I think it applies beautifully to veterans. It's also now being used for criminal offenders. So sex offenders, domestic violence kind of cases. When we look at how do you help someone be honest about what they did, not forget it, not pretend it didn't happen, but then live with it. How do you live with something you did that was so bad? So these are interesting treatments. Mentalizing approaches. I would encourage any of you, this again is something relatively new to me, it may be more in the curriculum now, but this is a popular approach for treating borderline personality. It's being applied in different areas, such as with teenagers, for example, multi-problem teenagers. I think this has got the most promise, and that's why I gave it its own slide. This is a beautiful approach to dealing with moral injury because it addresses meaning. So Peter Fonicki, Luyten, John Allen, and some others that you recognize have developed this psychodynamic approach, but it's manualized. It's studied. You can study this. You can do research studies, trials with this. So mentalizing therapy. One hint of how important this is from a Portuguese study. I apologize for my Portuguese. For Ferrao and Oliveira, but they looked at moral repair, recovery from moral injury, and they discovered that self-awareness, mindfulness, the mentalizing ability of these patients. These are veterans, Portuguese veterans. Integrating the story into the personal schema, the narrative. So this is kind of like narrative therapy, and then perceived social support. So the patients, the veterans who did the best are the ones who had good mentalizing skills, they had good social support, and they had integrated the narrative of what happened into their sense of self. Like, yes, that happened, but I'm a soldier, I'm a professional, that kind of thing. These are the ones who, this is a naturalistic study, not an experiment. The ones who were doing the best are the ones who had that quality. In our work with the moms, the psych patients and so forth, we're seeing a very similar quality. The people who do the best, like the administrator that I mentioned, she's using faith, but she's very good at recognizing who's who. Like, this is my stuff and that's your stuff. She's keeping it separate. She is aware of who she is. She has a good self-definition, good self-awareness. So we're seeing similar stages. I gave you lots of examples of people who are not mentalizing. They're in denial. They're in different stages of this. The people who seem to be doing best in our sample, our preliminary sample, our early work, are the people with better mentalizing skills. I'm almost at the last slide. So community level treatment. I talked about community level moral injury. So one question, I'll just mention it quickly here, is how do communities go wrong? How does it end up that communities can accept something like widespread child abuse or harassment of a certain ethnic group? How does it happen that a group can widely adopt the set of values that, on the one hand, at a conscious level, the rules, the laws, for example, say you're not allowed to do this, you're not allowed to be racist or violent, but it happens all the time. It gets ignored. The example in Ghana that I mentioned is that the laws say one thing in Ghana about how to take care of widows and property transfer, inheritance, but society does something totally different. We could come up with multiple examples in any culture you want, where the rules are one thing, but behavior is different at a cultural or social level. So this has been addressed at a social level. The South African Truth and Reconciliation Addressing Racism years ago, that was one of the first attempts at this, of an official attempt to mentalize, to be aware, self-aware, to make this public of what happened and to make progress past the moral injury, to find forgiveness and make amends. So transitional justice is a term you can read up on. It's an official term, a set of programs through the United Nations that addresses this. So often, so many places in the world, bad things are being done. So how do you get past that? How do you help communities get along with each other and forgive each other, but be honest about what happened? So transitional justice. There's a beautiful essay by Ta-Nehisi Coates in The Atlantic that was on reparations, not slavery reparations, but more recent problems of racism in this country in terms of like property distribution and so forth, economic problems. A nice essay to read in this area. And then community-based, Cheryl Robertson, I mentioned from the nursing school, is also doing this. She doesn't know she's working in moral injury because I haven't talked to her about this recently, but she's doing effectively helping communities that are under severe stress come together and help support people who are hurt by these wartime experiences and move past that as a community. All right, the last painting and next to last slide. This is the intervention of the Sabine painting. This painting was done at the end of the French Revolution, a time when factions had bloodied each other badly, and they needed to come to some resolution. They needed to find forgiveness and understanding and honesty. So this painter, who was a militant on one side, painted this from the original stories, the origin stories of Rome. So this is the Roman tribes fighting with the Sabine tribes. You may be familiar with other paintings, the kidnapping of the Sabine woman. So in this case, this part of the story is at the end of the story where the Sabine women say, enough, okay? You're gonna talk to each other, we're gonna stop the fighting. So this is a nice finding peace, between warring communities. That's the theme of this painting. Okay, so in summary, moral injury is by definition severe and lasting. It's determined by both internal sense of meaning and social aspects. It's probably rare. At this point, we don't really know. We don't have any epidemiology of this, but we think it's probably rare because it's severe. It occurs in diverse populations. That's one of the new findings from our work, is that looking at it, it appears to be quite widespread. Effective treatment, I'm arguing effective treatment is going to involve, it's going to change the meaning. That would be the focus I would have. This isn't a physiologic problem that you can fix necessarily with medications. It's going to be a therapy kind of issue, and it's going to focus on the meaning of what happened and how you move past that. The mentalizing therapies that I mentioned. And a lot of research still needs to be done. That's why we're having a blast doing this, is because there's like years worth of work to do, so we're having fun. Okay. All right, this is the last slide. There's a contact email address. I'm happy to get emails. I can give copies of slides or references if you just send me an email. And then my colleagues that I'm working with, social work colleagues, Wendy Haight and Amy Krentzman are professors in social work, and they're grad students there. Okay, thank you.
Thank you.